good evening, everybody. This is Stuart Schlossman from MS Views and News. How are you all doing? That's great. I'm really glad to hear that you're all doing great, okay? So we are here tonight to do Compass to Care, Rural America and beyond, okay? And we say beyond because these programs, obviously, they're virtual, and they're not just going to those in rural America. So people are able to see them from all across the United States and outside, you know, if they wanted to join what we're doing here. And that's great. So tonight we have our guest speaker. We have Dr. Aaron Boster. We have several different topics that we're going to be discussing tonight, or that Dr. Boster is going to be discussing tonight. And then we're going to also be doing Q&A. So we've already fielded many questions from those of you that registered previously. Okay, I know you asked questions. If you have any more questions to ask, we do ask you to please type them in online, and we'll get to your questions tonight, all right? We're going to try answering, not me, but Dr. Boster is going to try answering every question that we are able to present to him. So whatever you can do, send in your questions. Even if you thought maybe you sent it in before, send it in again. If we see it again, we'll just cross it out, and it will not get asked twice. All right. Again, tonight's program is the Compass to Care Rural America, and we have two sponsors for this program. I'm sure you could see them on the screens behind me, but if not, we have Novartis and Genentech to thank for their support in doing tonight's event. Okay, and I am wearing a mask only because, again, we're in a studio, all right? We're in a production studio. We have people here, okay, and I want to keep my spray to myself. Okay, and everybody out there should be doing the same thing. Whether you believe it or not, it is happening. Your spray does get out there. People are getting infected, and life is going on, but life is not for many as well. All right, let's get started with tonight's program. We have Dr. Boster. Dr. Boster is in his home studio. He's going to speak with you. He's got a chalkboard behind him. He's going to let it rip. He's going to let's just get going. Okay, thank you. Take it away, Dr. Boster.
Stuart, thank you so very much. Howdy, everyone. Good evening. My name is Aaron Boster, and as always, I want to thank you for learning about MS with me. I want to say thank you to MS Views and News for this opportunity to speak to you. Of course, our sponsors, Novartis and Genentech, thank you very much for making this possible. I'm at home. I ran home after work. My wife gave me this chalkboard in case I feel like we need to do some drawings, and I am tickled to death to talk to you about multiple sclerosis and how to beat it. There's a bunch of topics that we're going to be covering tonight, and as you have questions, type them in, and I'm going to answer them for you. Looking at my list of questions, the very first question I was asked about is talking about what is MS and how do we live with it, and that's a really important place to start. When we think about multiple sclerosis, we think about the immune system. So the immune system is a bunch of little white blood cells which are made inside the bone marrow. And when they're born, they don't know what they want to do yet. They're not sure what they're going to be when they grow up. They're kind of like college freshmen. They haven't figured it out yet. And they go to school up in the thymus, which is in your neck. I like to call that T-cell university. Now, T-cell university is a very weird college for a couple reasons. Number one, it's free. So it's not like any university that I ever attended. And number two, they let all the cells in. So any cell that is born gets to go to T-cell university. Now, number three, at T-cell university, there's only one class. Are you able to differentiate self versus non-self? So if I show you one of your own cells, can you identify that as you? And if I show you a foreign invader, if I show you a virus or a bacteria or a parasite, can you identify it as a foreign invader? Now, if you pass the class and you graduate from T-cell university, there's only one profession, soldier. Quite literally, they give you weapons and you tool around the human body looking for bad guys. And when you see a bad guy, what do? Well, you stop, you get out your iPhone 11, you take a picture of it, you send that picture to all your friends converge, and you stomp that virus to death. Then you keep a picture of that virus for the duration of the life of the human being. And every time those cells see that foreign invader, they attack it. So when someone tells you that you can't get chickenpox more than once, that's false. You can get chickenpox 100 times. But after the first time, your immune system built an arsenal against chickenpox. So the second time you see chickenpox, wow, you just knock it out of the park. Now, let's go back to T-cell university. What happens at T-cell university if you fail the course? Well, remember how I told you it's a weird school? They take you out back and they shoot you in the back of the head. They literally murder any cells that can't tell the difference between self and non-self. Theoretically, only cells that graduate can do that. Now, every once in a while, there's a mistake. One of the students doesn't study properly, he fails the test, they forget to murder him, and he graduates. And he graduates with his friends, he becomes a soldier, he gets his weapons, and he tools around the human body. But he sees something that he thinks is a virus, but it's not, it's part of you. But he thinks it's a virus. He gets out his iPhone 11, he takes a picture of it, he calls his friends over, he says, that's a virus. They pound on it. The problem is, it is part of your body. And that's the underpinnings of autoimmunity. An autoimmune process is where the immune system inappropriately attacks part of you. Now, if that attack occurs in the pancreas, we call that type 1 diabetes. That's an autoimmune disease that attacks the pancreas. If that attack occurs in the joints of the hand, we call that rheumatoid arthritis. That's an autoimmune disease that attacks the joint. Multiple sclerosis at its core is an autoimmune disease that attacks the holiest of holies, the supercomputer that runs the body, the brain, and the superhighway, the spinal cord that takes all the information from the brain down to the body and back up. And the most common form of multiple sclerosis we call relapsing multiple sclerosis. And relapsing multiple sclerosis is hallmarked by attacks. By attack, a flare, an exacerbation, a relapse. That's when something bad happens neurologically, when you lose a function and it sticks around for a couple of days and you can't hide it from your wife. And you have to say, honey, I can't see out of my left eye. And when you have an attack, you can recover from that attack, but you don't always recover fully. You can have a partial recovery. And so in the example of an optic neuritis where someone lost vision, maybe it returns half. Maybe they're legally blind, but they can still see color and shapes. They have accrued neurological disability. And as you move forward in time with repeat attacks, with repeat insults causing brain damage to the holiest of holies, you can accrue neurological disability. All people impacted by MS, whether that be a relapsing form, the most common form, or a progressive form, which we'll talk about in a bit, can accumulate neurological disability from incomplete recovery, or they can accumulate disability independent from attacks. And people can say, I used to be able to walk unlimited, and now in the last year, I really can't get terribly far. And if you fast forward, they might need an assistance device. MS is the leading cause of neurological disability amongst young people in the United States. And yet, increasingly, it is a treatable condition. It is something that we can rally against. And I wanted to start our discussion tonight by sharing with you my opinion of how to beat MS and how to make MS boring. And it boils down to being 5 for 5 in your fight against MS. I want you to be 5 for 5 in your fight against MS. And what does that mean? That means there are 5 things that I want you to be doing all day, every day. What are they? Number 1, I want you to not smoke cigarettes. Smoking speeds up MS by 50%. If you smoke, you increase the likelihood to develop MS by double. And if you have MS, you speed up your disease process, unfortunately, quite a lot. But the good news is, if you quit smoking, you slow it back down. And that's a really big deal. And when I talk about being 5 for 5 in your fight against MS, the first thing is to not smoke cigarettes. I will punctuate that comment by a sip of apple juice. That's delicious. Number 2, in being 5 for 5, is to exercise as part of your lifestyle. People impacted by MS that exercise as part of their lifestyle become less neurologically disabled over time. They have better cognition. They sleep better. They have more energy. They have less falls. All of this is scientifically proven. But if you think about exercise, think about the following experiment. So we clone you. Now there's 2 of you. So we'd have to talk to your spouse and make sure they're okay with it. But hypothetically, I now create 2 of you. Clone A and clone B. Clone A, I give an elliptical and carrots. And clone A is hoofing it. They're on the elliptical, they're eating their carrots, they're exercising. Clone B, I give a television with Days of Our Lives TV and chocolate cake. And so clone B maxes and relaxes and learns a lot about Days of Our Lives television. Now let's get back together in a couple years. Clone A is a Greek goddess. Clone A has a strong core. And Clone A has great lung capacity and her heart is in shape and her legs are strong and her balance is better. Clone B found the weight that Clone A lost, put on a couple extra pounds, is a little bit out of shape, has a weak core, weak lungs, legs aren't awesome. All right, so I have Clone A and Clone B. And then they both suffer an attack of left leg weakness. Clone A is limping. Clone B is now fixed in a wheelchair, looking up, wondering what happened. And I'm not going to insult those of you that have jumped online tonight asking you which clone you rather be, because it's obvious. We want to be Clone A. When we talk about being 5 for 5 in our fight against MS, the first one is to not smoke. The second one is to exercise as part of your lifestyle. Number 3 is diet. When we talk about diet, the number one thing we want to do is supplement low levels of vitamin D. Now, I live in sunny Columbus, Ohio, and it is October, and the sun is gone, and it's not going to come back out until about May. Literally, October, November, December, January, February, March, April, we don't really see a lot of sun here in sunny Columbus, Ohio. And so we can't get our vitamin D from the sun. And when I check levels of my patients here in central Ohio, I get rock bottom numbers like 9 or 11. Now, the reality is that low levels of vitamin D drive MS faster. And if we can push your level up above 50, but under 100, so I want it between 50 and 100, it slows the disease down. And so number 3 and being 5 for 5 in your fight against MS is to supplement low levels of vitamin D. And I'm going to kick it up a notch tonight and talk about eating clean. I challenge you, I double dog dare you to avoid fast food, fried foods, processed foods, sugar-laden foods. And if you do that, if you eat real food, if you eat food that has ingredients like apple, chicken, asparagus, you will be absolutely amazed at how much energy you have, at how much weight you lose, and how much better you walk, and how much better you think. It is remarkable. So number 3 is to supplement vitamin D and eat clean. Number 4, and being 5 for 5 in your fight against MS, is to take a disease-modifying therapy, to take a DMT and make sure it's working. And we're going to come back to that important point, because it's not enough to treat your MS. We have to treat it and make sure it's working. And in the modern era where we have 22 different FDA-approved DMTs, it's unacceptable to undertreat your disease. It's unacceptable to be taking a DMT and have an attack. And so when I talk about being 5 for 5 in your fight against MS, number 4 is take a DMT. What's number 5? Number 5 has never, ever been more important than it is today in October 2020, when we're dealing with a global viral pandemic and there's a mental health crisis internationally. I have treated more depression, more anxiety. I have treated more psychiatric symptoms than I've ever treated in my entire life because of this global viral pandemic. And number 5 is stress management. It has everything to do with learning how to, on a daily basis, actively manage your stress, whether that be mindfulness, meditation, taking a personal day, what have you. It's terribly, terribly important. It is my opinion that in 2020, we can't cure MS, we can't make it go away, but we can make it boring by being 5 for 5 in our fight. And with that introduction, Stuart, I want you to jump back in here, and if there's any questions about what I've said, bring them together and we'll answer them together.
Hey, doctor.
Howdy, howdy.
Hey, doesn't that look great? You know, this with the screen behind me, it looks pretty awesome, right?
I think you look superb.
Thank you very much. Thank you. I appreciate that. So I'm going to take this off. I just wanted everybody to see that, you know, this is a great looking logo, you know?
I think it looks fantastic.
Yeah, I thought so too. Thank you. Diagnosis and progression and relapse. So a person writes, how do I know what type of MS I have?
So that's an excellent discussion. And of course, as I give answers tonight, and Stuart, I know you know this, I can't answer for that person specifically because I don't know them. So I'm going to provide answers that are more general. And to know the specifics about you, you have to talk to your provider. So with that out of the way, how do you know what kind of MS you have? There's really 2 kinds of MS. There's a relapsing form of MS and a progressive form of MS. And a relapsing form of MS is characterized by an attack, by a relapse, by a flare, by an exacerbation. in my biased medical opinion, if you've had an attack, you have a relapsing form of MS. Now, it doesn't mean that you had to have an attack recently. It could have been 20 years ago. Now, the other kind of MS is called primary progressive MS, where people slowly accumulate disability and they've never had an attack. You explain an attack to them and they look at you like you're an alien. And so if you've suffered an attack where you lost a function, maybe over hours to days, and then you didn't have it, and then a couple weeks to months later, it returned fully or partially, you suffered an attack and you have a relapsing form of MS. Awesome question.
So going further though with the primary progressive, we had gotten emails recently in the last 2 weeks from different people that wanted to know how they switched from relapse remitting to primary.
So they didn't. So
Exactly.
using the definitions that we have today, which were revised as recently as 2014, you either have a relapsing form of MS or primary progressive MS. Now, if you have a relapsing form of MS, some doctors over 20 years will determine that that patient has transitioned and they have a secondary progressive MS. It was primarily relapsing or remitting, and secondarily they started to develop progression independent from attacks. And we call that secondary progressive MS, which is a form of relapsing MS and which still responds to disease-modifying therapies. But you can't go from relapsing MS over to primary progressive. That doesn't happen. Those are different.
Right. So going on what you were just speaking about going though from relapse remitting to secondary progressive, how do they know, or please let them know how they can tell if their secondary progressive is triggered anything new happening?
So that's a really important point. Back in the ancient days of yesteryear, just even 10 years ago, I had a lot of patients that would say, please don't tell me I have SPMS. Don't tell me I have secondary progressive MS, because it's a sense that you have stage 4 cancer and that there's nothing to offer you, which is completely false. The reality is that people with secondary progressive MS have a relapsing form of MS. They can still have attacks, but their disease is now characterized predominantly by a slow, steady progression of disability independent from attacks. And both are relevant and both respond to disease-modifying therapy. Allow me to repeat. If you have a form of MS where you haven't had an attack in a long time and you have accrued neurological disability, and essentially you have what we might in the day have referred to as secondary progressive MS, we can treat that successfully with disease-modifying therapy because we can prevent your risk of having an attack and we can slow disability progression with these medicines. That is very, very important.
So how does a person know when they are actually experiencing a relapse?
It's the formal definition, Stuart, is a new neurological deficit or an old deficit that's been gone for a long time and it's returned, which lasts longer than 24 hours, which has objective exam findings to buttress what the person tells you in the absence of a fever. Oh, that's a lot of words. So let's instead use English instead of medicalese. A relapse is when something goes wrong and you can't blow it off. And it's happened over a day or two and it's sticking around and you can't ignore it any longer. And it happens. And the one thing that I do want to point out is we have to make sure that you don't have an infection. All right. Because if you have MS and you have a urinary tract infection, you are going to have old symptoms come back out. And that's not an attack. That's called a pseudo attack. And if we treat the urinary tract infection, we make the neurological symptoms better. So it is relevant that we check a urinalysis. Now, the reason I bring that up is I, as an MS neurologist, am doing a lot of telemedicine these days. I'm seeing 70% of my patients just like you and I are talking right now on camera. And unfortunately, people are having attacks very frequently these days with COVID and with everything else that's going on, with the stress of life. I think there's a lot of attacks. And so I can treat someone from a distance, but they have to stop by a laboratory and get a urinalysis so I can make sure they're not infected before I treat them.
Okay. So can a person be getting a relapse because their medication stopped working for them?
Yes. So if you're on birth control pills and you get pregnant, it didn't work, because the goal of a birth control pill is to prevent an unplanned pregnancy. Now, if you have 3 kids and you start birth control, you still have 3 kids. They don't go away. And if you wonder why you're on birth control, go hang out with your 3 kids and you'll remember why. Exact same thing with the disease-modifying therapy. When we take a DMT, the goal is no attacks. That's the goal. The goal is no new spots on MRI. That's the goal. The goal is no change on exam. That's the goal. And if you're taking a DMT the way you're supposed to, and you have an attack, God forbid, or you have a new spot on your MRI, or you have new neurological disability, it's not working. And that may be despite you taking it properly and doing all the stuff you're supposed to do. That can happen. And when that happens, we have to discuss whether it's time to upgrade your therapy to something different, because it's not doing what we want.
So what happens if the MRI shows no new spots and yet the body is weakening, or it becomes more difficult to walk or more painful to walk?
So that's real, and I'm going to answer your question 2 ways. When we learn about someone impacted by MS, we use 3 tools to teach us how they're doing. Tool number 1 is the very most important, what they tell us, because they are a them expert. You, Stuart, are a Stuart expert. You know more about Stuart than any other person on earth. And if I listen carefully, you'll tell me 90% of the answers that I need to know just by listening to what you have to say. That's the most important. Number 2 is what we see on the MRI. And so the MRI takes a picture of structure. And if we see a new spot, or if we see a bigger spot, or if we see a spot that's lighting up when we give contrast, that's bad. Number 3 is what we see on examination or on clinical testing. And so sometimes we do a full neuro exam, sometimes we do validated testing. But here's the kicker, Stu. They don't all have to go together. So you can have a person that feels awesome and their exam is fantastic and their MRI shows new spots, and that's breakthrough disease activity. Or you can have someone where the MRI is gorgeous, there's nothing new, and they have new neurological disability, and they don't have to align. Now, I want to try to use this chalkboard that my wife was nice enough to give to me, because I'd like to talk to you about different kinds of progression. Should we try it out?
Sure.
All right. So can you guys still hear and see me?
Yes.
All right, super. So I want to show you a new concept in MS, and it breaks down like this. So this is a graph, and as you go this way, you get older. So time goes this way, right? So you go from being younger to being older. And as you go up, you become disabled. So as you go up, you accrue disability. Now I want to show you someone with MS. We're going to use an example. Someone goes along and they have an attack and they get all the way better. Here's someone where over time they had an attack, maybe they went blind in one eye, and fortunately got all the way better. Now, then they have another attack, but they don't get all the way better. So here in this example, maybe they had burning in their arm and only got 50% better. And so they have now accrued neurological disability from incomplete recovery. And then let's say over time, they have progression, right? I want to break this down for you. See this space here? This person didn't get all the way better. So they accrued neurological disability from incomplete recovery from an attack. Does that make sense? Because they had an attack and they didn't go all the way back down. And we call this relapse associated worsening, or RAW. Now, what about here? This space here, this person accrued disability and they didn't have an attack. So what's that? That's called progression independent from relapse activity, or PIRA. And you can have accrual of disability from RAW or PIRA. Now here's the important part. disease-modifying therapy treats both, and that's very, very important. So thank you for letting me use chalk for a traditional chalk talk. And Stuart, thank you for queuing up those questions. I'm grateful. We're going to jump into another topic, and the next topic that we're going to talk about is, oh, Stu, was there another question? I'm sorry.
There are so many questions, but we can either do some now or we can go back to some later on or something. But I wanted to stay with the topic. So, yeah, I wanted to stay with the topic.
More questions on the topic. That sounds great.
Another person asks, in how many years can an MS patient stop treatment? And I feel that this is an important question that I've heard from many people, so we would love to hear your response.
So the question is, at what point can you stop taking therapy? And so I have a very, very strong opinion about this topic, and I'm going to give you a very definitive answer. I believe in my heart, I believe very firmly that you should never, ever continue therapy after death. I don't think it's appropriate to continue to give someone a disease-modifying therapy after they're dead. That doesn't make any sense to me, because you can't get the medicine in them. Their immune system doesn't respond. Their nervous system doesn't respond, so it's nonsense. So that's where I think we should never, ever treat people impacted by MS, is at death. Now, if you're not dead yet, I ask a simple question. Do you have an immune system? And if you have MS and you have an immune system, if you're 50, 60, 70, 80, it's still there and it's still revved up. And then a very important question, do you have a nervous system? Do you have nervous functions that you like? For example, swallowing, seeing, hearing, having an orgasm, walking up a flight of steps, reaching for something. These are all neurological functions. So if you have a nervous system and you like it, and you have an immune system that's trying to attack it, I want to do something to intervene. And so I think it is critically important that we continue to treat people impacted by MS. Now, I want to make a point. This morning, there was a clinical trial paper that was published, which looked at advanced multiple sclerosis, all right? These were people that were in a nursing facility that had very advanced MS, or they were in a rehab facility, they had very advanced MS, and they followed them over 2 years. Guess what? They got worse. So just because you have advanced MS doesn't mean that you're done progressing. And these medicines work to slow progression. So I think it is very important that we keep on keeping on. And I think it is nonsense, if I'm honest, that we make some arbitrary comment that after 60, you've had a nice life, so it's okay to stop. Or after 55, you've had a great time, so we can stop treating you. I think that we want to keep treating you to keep the disease at bay. I feel very strongly about that.
So common that it is that people say, hey, you know, I'm over 50 years old. I haven't had relapses in umpteenth amount of years, depending on the person. And they feel that, you know, if nothing's been happening, then they should stop. And, you know, my answer to them is, well, maybe, and correct me if I'm wrong, all right, but maybe you've stopped getting worse because you have been doing these treatments, and maybe you shouldn't stop.
Exactly right. So if you think about cholesterol medicines, so I have high cholesterol, thanks, Dad, and I'm supposed to take a cholesterol medicine to lower my cholesterol. So should I at age 55 say, well, I had a good run of it, I'll stop my cholesterol medicine if I have a heart attack now? You know, at least I had, you know, a couple good years. That's nonsensical. And if you're 5 for 5, if you're exercising and not smoking and eating and supplementing vitamin D, and you're managing your stress and you're taking a therapy and you're living your best life despite having MS, I don't want to stop anything, nothing. I want to keep on keeping on. And I don't want to let MS make decisions for you. I don't want to let MS require you to sit in a chair. I don't want to let MS remove you from the playing field or the boardroom or the bedroom. I want you to keep on keeping on. And the very best way to do that is to keep fighting.
Okay, great. Now, I'm going to ask you one more question, then I'm going to let you go on to something else. There are a lot of not repetitive questions, but there's a lot of things that concern the same subject with different medications. We will get back to that. I want everybody to know that we will get back to that, all right? I'm not going to let Dr. Boster off this call. Oh my gosh, his wife is going to be calling him later on to eat something. But we're going to try to get him to stay on until we can try to answer as many of these questions as we can, okay? So without me speaking any further, let me just ask this next one, and that is, let's see, this person wrote it right here. It's basically, I forgot where it went. Okay, have you heard anything about nerve regeneration?
Yep. So to manage MS, ideally, we need three kinds of therapies. All right, we need three different kinds of therapies in combination. We need an anti-inflammatory agent, right? So an anti-inflammatory agent, something to quell inflammation in the brain and spinal cord. And today in the United States, we have 22 different anti-inflammatories. All of the MS medicines that we might list out, the ones that are created by the sponsors that are behind you on the wall, the ones that are created by other pharma companies, they're all anti-inflammatories, which is fantastic. And that's a really, really good way of addressing MS, but it's not complete. The second therapy that we need is we need a remyelinating agent. We need something where when you strip the plastic coating off the wire, you can put the plastic back on the wire, all right? A remyelinating agent, and we don't have that yet. In fact, this past week, unfortunately, one of our hopeful remyelinating agents, ofetumumab, also called antilingo, was found to be negative in a trial, and so that's a bummer. But we're not done trying, and we will find a remyelinating agent. The third thing that we need is a neuroprotective agent to protect the neurons, the nerves that that person was referencing, and that doesn't exist yet. So it's my hypothesis that in the future, when we treat multiple sclerosis, we won't use one class of drug, we'll use three to really, really stick it to the disease. But we're not there yet. We haven't created those drugs yet. We're still working on it.
Okay, great. Thank you for that. And now I'm going to let you get on to the next topic. And you have the list in front of you. I don't have it in front of me. And I'm going to let you speak about that for about 10 minutes, 15 minutes, and then we'll get back to some more questions, okay? Everybody, if you have questions to ask, just ask them, and we will try to get to them all. Thank you, and I'm off of here until you tell me to get back on, or sooner.
Deal.
Bye-bye.
So the next questions that I see on my list, or the next topic on my list, is discussing the available MS treatments. Now, that is a 4-week discussion because there's a bunch of therapies. And I remember back when I started in MS, there was only 3 therapies, so it was really easy to talk about all of them. And so I want to try to go over the mechanism of all of the therapies in under 5 minutes. So let's see if I can do it. So the first therapy I'll talk about is Copaxone, or glutamer acetate. And there are several generics that are out there now. And this is a shot that you take thrice weekly or once daily. And what Copaxone does is it keeps showing your immune system the target, myelin. It keeps showing it day after day after day after day. And eventually your immune system kind of gets bored and it kind of learns that myelin's not that big of a deal. And so when your immune cells see the real deal Holyfield, myelin in the brain, they don't attack it as much. And that's Copaxone. Now, interferon beta is a class of medicines that includes Extavia, beta-seron, Rebif at a high and a low dose, Avonex, Plegridy. There's a bunch of interferon products that are all injections. And the way interferons work is they tighten up the blood-brain barrier. So I'm going to use an analogy of the 3 little pigs. So remember the 3 little pigs where the big bad wolf would huff and puff and blow the house down? So the nascent MS person has a blood-brain barrier which separates the bloodstream from the brain, which is kind of like the straw house in the 3 little pigs. It's not a very good house. And so it's really easy for the big bad wolf to get through it. But when you squirt interferon on the straw house, it becomes the stick house. It's a better house. It's a better barrier. It's not a perfect barrier, but it's a lot better. And so by blocking cells from leaving the bloodstream and entering into the brain, we can slow down multiple sclerosis. Now, the next drug that I want to talk about is Tysabri, or natalizumab. Tysabri is one of the 3 highly, highly effective medicines. It's one of my faves. And the way Tysabri works is it turns the straw house, the blood-brain barrier, into the brick house. And then we have to sing, she's a brick house. All right, I'll stop. Oh, mighty, mighty, letting it all hang out. So the stick house becomes the brick house. And now with Tysabri, you have a barrier that's literally impenetrable. And so it prevents naughty autoreactive cells from gaining access to the central compartment. And that's how Tysabri works. Now, there's a class of medicines that are called S1P1 receptor modulators, and that's a mouthful. We're talking about Gilenya, and we're talking about Mayzent, and we're talking about other drugs that have come to market that are S1P1 receptors. They work in a very interesting way. They trap about 80% of your white blood cells in your lymph nodes. So typically the white blood cells float around the bloodstream, but every once in a while they go into a lymph node, then they come back out. And what these drugs do is they trap the cell. When it enters the lymph node, they can't leave. It's like Hotel California, where you can go in, but you can't exit. And by trapping the cell in the lymph node, it takes it out of the bloodstream. So if it's out of the bloodstream, it can't get to the blood-brain barrier, so it can't get into the brain. And so by taking an S1P1 receptor, you sequester cells in lymph nodes. And as long as you keep taking the S1P receptor, you keep them out of play, which is kind of a fascinating mechanism of action. There's another pill called Aubagio. Aubagio is a fascinating pill that you take once a day, and it causes your white blood cells to play the freeze game. They can't move. It doesn't kill the cell, it just makes it play the freeze game. It freezes it so it can't rapidly reproduce. And so what happens is you have less inflammatory autoreactive cells floating around, and it slows the disease down. There's another pill that came out called Mavenclad. The real name is Cladribine. Mavenclad is a fascinating drug, and it's taken in a very unusual manner. It's taken once a day for 5 days. Wait a month, you do nothing the rest of the month. And then on month 2, you take 5 days, and then you do nothing the rest of the year. I said year. And then on year 2, you repeat that, and then you're done treating. Because what Mavenclad does is fascinating. It reboots the immune response. It knocks down the B and the T cells, B more than T, and then they come back, but they come back nicer. And so that's the way that Mavenclad works. Now, I've got a couple other drugs to go through. I left some of my faves for last. There's a B-cell killer called ocrelizumab, or Ocrevus, and that's an infusion in the vein that's taken twice a year. And there's another drug that just came to market called Kesimpta. And Kesimpta is an injection once a month that you give yourself, where you inject yourself once monthly. Both of these drugs are B-cell killers. Now, the immune system is made up of the T cells and the B cells. And the T cells are the ones that go in your brain and attack your brain. But the T cell cannot do it without the B cell helping out. And it makes me think about when I was back in high school. So I went to a really big high school. I graduated with over 700 kids in my class, and it was very crowded. And in the hallway, sometimes 2 guys would bump into each other. And if you bumped into a guy, there was only one way to settle that dispute. You had to meet behind B building at 3:30 and beat the shit out of each other. And you'd have these fisticuffs. And I went to some of these social events where I would watch 2 young men defend their honor. And what I noticed was fascinating. Only guys showed up when they brought 10 of their very closest friends, right? So in this analogy, the pugilist, the fighter, is the T cell, but his friends are the B cells. And those are the guys that egg him on and say, go ahead, whoop his butt. I got you. Go ahead. If he hits you, I'll hit him back. I'll hold your book bag. And the B cells rile the T cell up. Now, in this analogy, what we do is we simply murder all the friends. We knock out all the friends. So the T cell shows up and he looks behind him and there's no friends. And you know what he does? He goes home because he's not adequately riled up to attack. And that's quite literally what happens when you take these B cell killers. Absolutely fascinating and slows down MS quite a bit. Now, the last drug to talk about in the armamentarium is alemtuzumab, or Lemtrada. And Lemtrada is a way of rebooting the immune response. It's an infusion in the vein, taken 5 days in a row, wait a year, take 3 days in a row, and then you're done unless you have new disease activity. Why? Because what it does is it knocks down your B and your T cells a lot, and then they slowly come back up. And when they come back, they behave more well-behaved. They're less autoreactive. So that was maybe a little bit more than 5 minutes, but that is a quick, lightning fast summary of every single disease-modifying therapy currently available to treat MS. Stuart, I'm going to ask you to jump back on the line, and I'll entertain any questions that people may have about DMTs.
That is awesome. Thank you very much for that, and thank you for your words of wisdom. We do have a few questions about the medication. So the first one is, can you discuss more about the new drug Kesimpta? I know you just spoke about it, but if you can say a little bit more about it, then that would be great.
I'd be happy to. So Kesimpta, which reminds me of Yiddish. So
Yes.
I grew up in a home where my grandparents actually spoke Yiddish. And when I hear the word Kesimpta, ay veye shmir Kesimpta, it sounds Yiddish to me, you know? But it's not. It's a make-believe pharma word. And Kesimpta is a B-cell killer. Now, it's a B-cell killer, which is in a shot. So you get a syringe and you jab yourself. Now, that's not really the way you do it. This is just sign language for jab. And you inject once a month. Once a month, every month, you give yourself an injection at home. And that medicine knocks down your B cells. And by suppressing your B cells, you disallow the B cells to activate the T cells. And we studied Kesimpta recently. And about a year ago, we published the article that kind of shared how it worked. It was compared against Aubagio. And compared to Aubagio, it did a much better job, I think, of decreasing attacks and decreasing new spots. And so that's Kesimpta in a nutshell.
It's funny that you said about the Yiddish, because I hear Kesimpta and I say Gesundheit.
Yeah, exactly. That's exactly. It sounds like
Right.
it sounds like my grandparents are speaking back at home.
That's right. All right, so the next one is about Gilenya. All right, wait. Another one about Kesimpta is, does anything regenerate after a month?
So this gets into something called pharmacokinetics and pharmacodynamics, which are fancy doctor words for how medicines last in the body and what areas of the body they go in and so on and so forth. The bottom line is, in order to have suppression of your B cells, you have to take Kesimpta every month. And if you took a break, the cells would repopulate. And so Kesimpta is a medicine that you need to take every month in order to keep those B cells at bay.
Great, thank you. So the next one was, or is, I'm washing out the Gilenya to start a more effective DMT. How do I prevent myself from a relapse before starting the new DMT? My doctor has recommended steroids until I begin, I don't want to say the name of the drug, but before that they begin that medication, and what do you think?
So Gilenya, which is one of these S1P1 receptor molecules, a pill that you take once a day, has a rare incidence of rebound, meaning if you stop Gilenya and then don't do anything afterwards, there's a risk that the disease may rebound, all right? So it kind of comes back more severe and then it settles back down. And so obviously we don't want people to suffer from rebound. And so there's a couple different mitigation strategies. I actually use the same thing that doc uses. And if I stop Gilenya, it's my goal to start their next therapy ASAP. I mean, in under a month. But if there does need to be a delay of time, I give a monthly slug of steroids once monthly for every month that they're not on a new DMT. Now, that is not scientifically based. That is my own personal opinion or my own chili recipe, but it's not dissimilar to what that doctor was suggesting. By filling in the gaps, by suppressing with steroids to keep the inflammation at bay, to give us time to transition to prevent rebound.
Great, thank you. Now we have a very long question here. I'm going to try to scream it out as quick as I can. How wide is half Gilenya used because of unfavorable labs from patients? I was on a half dose, and now when MRI was done, I had lesions on the brain. I was never comfortable taking a half dose. Throughout the years, I've had many relapses and taken many series of steroids. It goes on, but I think it's still about this half dose. So if there's anything else you can say about it, that would be great.
Yep. So if you're prescribed an oral birth control pill, and the instructions are take a pill a day every day, and you take a pill every other day, we have a term for you. It's called MOM, because that medicine's not going to work and you're going to get pregnant. So when a medicine is prescribed and it's studied, we study the most effective way to receive it. And the best way to take Gilenya is to take it once a day. And when we've studied going every other day, it doesn't work as well. And people have breakthrough disease. Now, if Gilenya was the only drug available in the world, then we would have to put up with taking it every other day and experience disability and attacks and so on and so forth. But it's not. Gilenya is one of 22 different FDA-approved therapies. And so, in my opinion, you either do it the way it's intended or you do something different. Now, very, very rarely in my career, for very good reasons, I have asked patients to take Gilenya every other day for a period of time. And very humbly and very ashamed, I will admit to you that when I've done that, I've allowed people to have disease activity and have an attack. And I feel very bad about that. And so I do not prescribe to doing that as a routine practice. And again,
Great.
That's my opinion. It doesn't make me right. It just makes me opinionated.
Thank you for that. All right. Shannon out in LA. I'm going to say your name because it's been so long since I've seen you. All right. So here you go. With the newer drugs like Mavenclad and newer pills, are they as effective as the infusions like Rituxan and Ocrevus?
So Mavenclad has never been compared to anything but placebo. So we know that Mavenclad is better than not taking a medicine. That is a fact. Scientifically, we have not really compared it to other drugs. And so the real scientific answer is, all right, but isn't a very good answer. And in the real world, we have to make the best guesses we can with the best evidence that we have. So my opinion, which is just my opinion, is that Mavenclad is one of the most effective pills, but I don't think that it's better than the infusions. And that's just my opinion. All right, so you can disagree with me, some other doctor could disagree with me, but when I rank the medicines based on my studying all the drugs extensively, I think that the infusions happen to be the most effective. And then there's a cadre of pills, and within that cadre of pills, the king of the pills, in my opinion, is Mavenclad. And then there's a bunch of shots, which in my opinion are the least effective. So again, that's just where I weigh in, having spent 20 years studying this stuff. Again, someone else might have a different opinion.
Great, thank you for that. Ocrevus, is this the only approved treatment for primary progressive?
Yes. So in the United States, we have 22 different FDA-approved therapies for relapsing forms of MS, which is awesome. In the United States, we have one therapy that had adequate scientific evidence to support its use in primary progressive MS. That's ocrelizumab, Ocrevus. Now, in the Oratorio trial, which I participated in, we enrolled people with primary progressive MS, and we gave some of them Ocrevus and we gave some of them dummy drug. And compared to dummy drug, the people that were on Ocrevus accrued disability 25% slower, their brain volumes shrunk 20% slower, and they maintained their walking and their hand function and their cognition. And so if you have PPMS, I think you should be on Ocrevus if you're not participating in a clinical trial, because we can slow your disease down by taking that medicine. And that's a really big deal.
Okay, thank you for that. Next, not me, a person wrote, I feel really badly in my body with pain and fatigue about 1.5 weeks before my next Tysabri infusion. Do you get these complaints from your other patients?
Yes. So fascinating that Tysabri, after about 3 infusions, and this is an infusion that you take once a month, you create a stable blood level and you bind up all the receptors after 3 months. And so scientifically, you're not supposed to have fluctuations necessarily, except people are not textbooks, and some patients have 3 weeks of raw, and then they have a week where they kind of dip down. And not all patients, but some patients describe that. And it's actually been published and studied, and we don't exactly know why. Now, most patients, they notice it, but they find it just annoying, and the medication is helping them so much they don't want to change. Very, very rarely, someone will have that last week leading up to their infusion, which is miserable. And on a couple occasions, we've actually changed drug because of that. But when I say a couple, I mean a couple out of hundreds upon hundreds upon hundreds of people that I've treated with Tysabri over the years.
Okay, so now, not from anybody, but from me, for all of us that have been on Tysabri or are on Tysabri and who have turned JC positive, for my own self, my last 3 blood draws have turned me back to negative. How does that work?
So when I was a medical student, I thought that lab tests were yes or no, like a light switch, like it was either on or off. Now, the reality is lab tests don't work like that. And there's a risk of a very serious infection called PML if you're on Tysabri and you're JC virus antibody positive. And being positive is supposed to reflect the fact that you've been exposed to the virus. So an overly simplistic view is if your JC virus antibody is positive, then you've been exposed to the virus and you have a risk of PML. And if the JC virus antibody is negative, you've never been exposed to the virus and there's no risk. And that's actually too simplistic. Here's the deal, Stu. If you have a JC virus antibody test and it's positive and then becomes negative, you didn't unsee the virus, but your level of viral activity is so low we can't detect it. And so it's not that you don't have the JC virus, you do. It's so low we can't find it. And I want to point out that in patients like that, it's very, very, very unlikely to go on to get PML. Great. The people in whom I'm concerned about are not the people that are positive and the negative, 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 positive, negative, negative, negative. It's the people that are positive and then they skyrocket and they go from a low positive to a super high positive. Those are the patients in whom I'm quite concerned.
Okay, so for the many, though, that have been changed from their doctors from a 28-day regimen on Tysabri to a 6 to 8 week version, how does that benefit them?
So this is something that was developed after the drug was FDA approved. So it's actually very recent. And there's a couple really amazing MS neurologists around the country, like my friend Elliot Froman and others that have spearheaded this effort, where what they saw is the following. They took a bunch of people that were on Tysabri and they put some of them on every 4-week Tysabri, normal. And they put some of them on what we call now extended dosing. So they got their dose every 5, 6, 7 weeks, something like that. And what they found was over time that both groups controlled their MS. So whether you got it every 4 weeks or whether you got it every 6 weeks, there wasn't an increase in attack rate. It was still controlling your disease. But the people that got every 4 weeks, there was an increased incidence of PML compared to people that got every 5, 6, or 7 weeks. And so there is a theory, which is backed by this data, that by taking Tysabri less often, you decrease the risk of developing PML. And I do this in my own practice. If I have a patient, and I have many who have responded beautifully to Tysabri, they do really, really well, and they become positive in their JC virus, and they don't want to stop it. So instead of stopping it and subjecting them to risk of having attacks and disability, we simply go from every 4 weeks to every 6 weeks. And we believe that that lowers their risk profile.
Okay, I'm combining this next question. Thank you for that answer, because very, very useful with a lot of people that ask that question in other programs too. So the next one is a combination I'm doing that revolves around many questions, and that is, can a person that has tested JC positive go on to using other medications? And are there any other of the MS medications that are being used currently that they could never use because they tested JC positive?
That is a great question. So when we developed the JC virus antibody blood test, like the laboratory, the JC virus antibody test, it was invented and studied to assess PML risk in Tysabri only. That's the only drug in which we've tested it. So when you use the JC virus to assess the risk of PML with another drug, you're out in the Wild West with no data, right? And the question asks, if you are JC virus antibody positive, can you take another drug? Well, yeah. And so there has been cases of PML reported with most of the MS drugs, not necessarily as often or frequent as with Tysabri, JC virus antibody positive, but it has been reported. But here's the thing. We don't want to throw the baby out with the bathwater, Stu. We don't want to get rid of a highly effective drug because of an infinitesimally small risk of PML. And I want to explain what I mean. If you take the very worst scenario, I'm on Tysabri, I've taken it for 5 years, I've had prior chemo, and I'm JC virus antibody positive, then that risk is 1%. 1%. That means that out of $1, there's 1 penny of risk. And I think that that is a discussion. I personally don't think, therefore, we are required to take you off the drug. I think we are required to discuss the risk, and that is the highest risk. So again, if we talk about Tysabri, if you're antibody positive and you haven't started the drug yet, the maximum risk that you can have in that first year is 1/100%. So you take $1 into 100 pennies, you take it 1 penny into 100 slivers, and 1 sliver is your risk. Now, it's not my right to tell you that's okay. It's not my right to tell you it's not okay. It is my obligation to educate you on the risk-benefit profile and then to shut up and let you tell me how comfortable you are. And so can you take other drugs? Yes. Should you? Yes. Should you go untreated? No. Good question, and thank you.
Great. 2 questions left in this category, and then we'll let you get on to the next subject because we have a lot to do and your time is running short as well. The person wants to know what your thought is about ofetumumab, and for those that don't know, that's also Kesimpta.
So that's right. So every drug has to have 2 names because it would be way too simple if there's only 1 name. So Kesimpta, which sounds like Yiddish, is the trade name or the branded name for ofetumumab. Ofetumumab is a B-cell killer that I'm quite fond of. Now, I have a preference for the efficacy and the way that ocrelizumab works, which again doesn't make me right. And I think it's awesome that we have options. I think it's awesome that we have options for self-injections and for infusions. And I think that the class of medicine, that B-cell killers, is really, really good. So we don't have any data to say that Ocrevus is better or worse than Kesimpta. I have a lot of experience with Ocrevus, and I love not making someone take a shot, all right? But I bet you there are people out there that would like to take a shot. And maybe there's reasons why them taking a shot at home is superior to other options. And so the punchline here is that options are awesome, and that Kesimpta and Ocrevus are 2 effective medicines, and I'm delighted they're both available.
Thank you. All right, the last question in this category is, what can you tell us happens at the blood-brain barrier?
So the blood-brain barrier is quite literally what it sounds like. You got the bloodstream over here, you got a barrier, and then you have the brain over here, the spinal cord. And the blood-brain barrier allows some things to pass through and some things can't. And so one of the many, many ways that we try to slow down MS is by enhancing the blood-brain barrier. So as I mentioned a little bit ago, interferon beta products strengthen the blood-brain barrier. So in the 3 little pigs analogy, they go from the straw house to the stick house. Tysabri enhances the blood-brain barrier even more. It goes from the straw house to the brick house. Drugs like cellenia and Mayzent, they move the cells out of the bloodstream so they can't even get to the blood-brain barrier. So the blood-brain barrier is one of many, many options for trying to interfere with the MS pathology. And it's a very effective way of trying to treat the disease.
Great, thank you. All right, it's your turn. Go on to the next subject. Thank you for those answers.
The options available for discussion, it would not be appropriate to have a discussion about MS without talking about ganja. So ganja, weed, pot, we're talking about cannabinoids in MS. And the question is, a topic is the use of cannabis as complementary therapy for symptom management in MS. And that's a topic that I have a lot of opinions about. So I'm a science nerd. I really like data. I really like statistics. And I like looking at my patients and telling them this science means this. And when in the state of Ohio, where I practice, there was a new law passed that medical marijuana became legalized, I kind of poo-pooed it. I didn't like it very much because the data, the science behind cannabis was very poor. And that bothered me. It still bothers me, actually. Now, there are reasons why the science is poor. Maybe there isn't money in studying it. Maybe it's very hard to study. The things that cannabis works on is hard to study, actually, like spasticity and pain. But I was kind of poo-pooing it, and then I did something that I try to always do, but I did something where I listened to human beings that I take care of. I started to listen to my patients, and I wasn't listening to 20-somethings that said they wanted to get high. I was listening to 70-somethings that didn't drink alcohol and went to church twice a week, and they confided behind closed doors that they didn't need Lyrica anymore, that they didn't need baclofen anymore, that they were sleeping through the night, that their irritability was better because their grandson visited from California and gave them a little weed or a little hash. And if they simply do this before bed, all these things are great. And I kept hearing this again and again and again. And I thought to myself, all these people can't be making this up. They can't all be like getting together and saying, hey, let's tell Boster this. I don't think that happened. And instead, what I think happened is I think that they had found that they were able to control certain symptoms by using cannabis. So I pulled the trigger. I spent a weekend taking all these online learning classes about cannabis, and I got certified as a medical marijuana recommender here in the state of Ohio. So if you fast forward, I've now been a medical marijuana recommender for just under a year, and I am a believer. I am a believer that cannabis can help some MS symptoms, not in every patient, but in some patients. So, for example, I think that in some patients, we have knocked it out of the park controlling neuropathic pain using cannabis. And these people are not using narcotics, they're using cannabinoids. And the other thing that I have found great success with is treating spasticity, spasms, cramps, Charlie horses, limbs that are hard to bend. This is very common. 70% of people with MS experience spasticity. And I have found that cannabis can help with that quite a bit. I have also found that cannabis can help with irritability. And lastly, cannabis helps a tremendous amount with insomnia, which is actually very common in MS. Now, this is all anecdotal, but look, I practice neurology in the real world. I don't practice in the ivory tower. I practice in the real world where real life human beings are trying to live their best lives. And if I can find a way to help someone not have spasticity, I think that's good. And if I can find a way to help someone with neuropathic pain, I think that's good. And so I think that cannabis is a tool. It's not the only option out there. There's other ways to manage pain. There's other ways to manage spasticity. There's other ways to manage insomnia. But this is a tool that I find very helpful. Now, I'm going to share some opinions, all right? I do not recommend that you take a carbon-based substance and light it on fire and then breathe in the smoke. I don't think that's a good idea because breathing in smoke is very pro-inflammatory, not just to your lungs, but also to your brain. And so it is not my recommendation that people smoke ganja. Now, I think that it's probably a bit safer to vape cannabis as opposed to smoking it. And for some of you on the call that are not familiar with vaping, I wasn't familiar with vaping. I had to learn about it. Vaping is where you heat up a concentrated liquid below the level of combustion. So it's not on fire. It's below the level of combustion, but it creates vapor. And then you breathe in the vapor. And it's less pro-inflammatory, in my opinion, than smoking. Now, I still think that it can be hard on your lungs, but I think less so than smoking. That's my opinion. And the advantage to vaping is it's very quick. So if you have trigeminal neuralgia, where your face feels like you're being stabbed, it's some of the worst pain that a human being can experience. And if you've figured out that cannabis helps with that, we don't have time to wait. You need to hit that vape pen and try to make that pain go away right now. There's another way to have a very fast onset of action without smoking, and that's using tincture. So tincture is an old pharmacology term where there's a liquid and you put it under your tongue and it's dissolved into the blood vessels under your tongue, and it's a very fast onset of action. But my favorite way to recommend ingesting cannabis is not by smoking, it's not by vaping, and it's not tincture. It's eating it. It's edibles. And so if you go to a dispensary in the great state of Ohio, they have myriad options for edibles. They have gummy bears, and they have brownies, and they have candies, and et cetera, et cetera. And the advantage of edibles is I think it's the least pro-inflammatory. I think it's the least likely to inflame your lungs and inflame the rest of your body. And it doesn't work right away. It has a slow onset of action. It can take 45 minutes to an hour and a half before it kicks in. And it can last for a very long time. So when I recommend medical marijuana to my patients in Ohio, I oftentimes recommend they buy a container of 10 milligram edibles, gummies, or what have you. And then I want them to take one, and I want them to not do anything else, just take one, and I want them to see what's the onset, how quickly does it start working? Does it start working at an hour? And then I want to see how long it lasts, and I want to see how much it helps with their spasticity or pain, and I want to see if they have any side effects. And once I know those four things, onset, peak, and when it wears off, side effects and benefit, I can help them dial it in like a medicine. And I have many patients that find they can do a gummy twice a day, and they're doing really, really well. And some of them don't need the old medicines that they used to use to treat spasticity, pain, irritability, and insomnia. So that's my 2 cents on medical marijuana. I do not think it's magic. I do not think it's the end-all be-all. I do not think that it slows MS, but I do think that it can improve quality of life, and I do think that it can help with symptoms. And thank you for letting me talk about that.
Thank you very much. And going forward with that, you know, I've had a lot of people complain to me that they take a gummy and they feel it's not working in 35, 40 minutes, so they take another one. And then it gets them into trouble. So how do you teach these people to restrain themselves to like wait that hour that you were just talking about?
What I recommend they do is 2 things. Number 1, tell their significant other, hey, I just got this medical marijuana. I'm trying to figure out if it works. I'm going to take a 10 milligram gummy. Don't let me take any more for the rest of the day, right? Because that way, if they reach for it, the spouse can say, didn't you ask me to tell you not to do that? The second thing is, I want you to use smartphone technology. If you're going to take a gummy for the first time and try to figure out if it's helping, set an alarm on your smartphone to remind you not to take anything else for the next several hours. Because the goal early on is to figure out if it works and to figure out how much it works. And so you don't want to have what we joke is a rookie mistake where you overdose yourself. And it's not going to kill you or cause you to be ill. It's just going to make you have a really bad afternoon. And I don't want that for you.
Okay, thank you for that. So you brought up about trigeminal neuralgia, and though this could hit close to home, I know that trigeminal for many people lasts a very long time, and for others it's like pick-like pain. How do they treat pick-like pain when you really don't know when it's about to happen, and is it worth really doing the cannabis to treat something like that?
So you're touching on a very important point, that some symptoms in MS are chronic. You have them all the time. Some symptoms are intermittent. They come and they go. Some symptoms are transient. They happen really quick and then they're gone. So if you have a spasm in your calf and you fish through your purse and you find your baclofen, and you swallow the baclofen, it's going to take 20 or 30 minutes for that baclofen to kick in. So it's not going to help that acute spasm. So what do you do in that instance? There's a couple options. The number one thing to do is to have something in the background to prevent it from happening, right? So if you have a form of neuropathic pain, but it doesn't happen very often, but when it happens, it rocks your socks. I mean, it makes it so you can't function. And I'll use the most common example in MS, migraine headaches. So you may only have a migraine headache twice a month, but you lose your entire day. You can't work, you can't function, you can't drive, you can't eat. And so losing 2 days a month is unacceptable. And here's the kicker. You don't know which day it's going to be. We give people with that situation a prophylactic medicine, something they take every day, heck or high water, to prevent an outbreak, to prevent them from developing a migraine headache. Now, going back to our conversation in cannabis, we may, if we find, say, cannabis helps with neuropathic pain, we may dose it a couple times a day standard, whether they're having pain or not, just to keep it from happening. So it is something that we can treat, Stu. And of course, we always have to weigh the risk benefit. So if I give you a medicine, whatever that medicine is, it's going to have side effects. And the benefit to removing PIC-like pain better be more important than the side effects that you're experiencing. Otherwise, it's not worth doing it.
Correct. Thank you. Which is why I hate using painkillers. All right. Which strain of cannabis is good for us to keep awake and not make us fall asleep? Do you know that?
The real answer is we don't know, right? The science in cannabis is profoundly lacking. And if you go to a dispensary, you might think I'm lying to you, because in the dispensary, they'll tell you a bunch of stuff. Oh, this is the best for this, and this is the best for that. And here's the kicker. It has not been studied, at least not scientifically using the scientific method. Now, speaking in gross generalities, there's two major landrace strains of cannabis. There's sativa and there's indica. Okay, so sativa typically comes from tropical areas around the equator. Indica comes from the Indica Mountains or the Kush Mountains in India and Pakistan, and so kind of a different climate. And speaking in gross generalities, indica tends to be more sedating, and sativa tends to be more activating. Now, the reality is that that's not always true, and the reality is that most strains that you purchase are a combination of the two. And so at the end of the day, there's unfortunately a degree of experimentation trying to figure out, if I use this particular cannabinoid, what are the benefits and what are the side effects? And I've had many patients who sign up for medical marijuana recommenders card, and they go to a dispensary, and after experimenting, they say, you know what, it didn't work for me. I was too tired, or I just didn't care for it. And that's okay too.
Isn't medical marijuana, or isn't the cannabis that's in medical marijuana also, doesn't it also contain CBD?
So most of them do. So when you talk about weed, like the plant that grows, right? So cannabis plant, it has a bunch of cannabinoids in it. Cannabinoids are the chemicals found inside cannabis. And there are literally hundreds of cannabinoids, hundreds. The two predominant cannabinoids are THC and CBD. Those are the two highest concentrations. Now, THC binds to CB1 receptors, which are found in the brain, and they have lots of effects, including, psychotropic effects, or making you feel high. CBD, the other most common cannabinoid, does not bind to TH1, or CB1. It does not bind in the brain. It binds to CB2 receptors, which are not found in the brain. So CBD has no psychotropic effects. You can't get high off CBD. And so naturally, if you see a cannabis plant, it's got all of those different cannabinoids. And if you find some type of cannabis, it may have a certain percentage of THC and a certain percentage of CBD. Now, there are plenty of people that believe firmly that having a higher CBD content helps them with certain things, and having a higher THC content helps them with certain things. And what I'll share with you is there's no science to guide you. And so I'm not saying it's true. I'm not saying it's not true. I'm simply saying I can't turn to scientific literature and tell you what's what.
Okay, thank you for that. Next one. First off, we're gonna be ending this cannabis discussion very shortly for those that are on here waiting to hear about COVID, because that, of course, is a hot topic, and we have a lot of questions for that. So the last one on cannabis, is there a specific blood test that they can possibly take to determine whether or not they should be using a certain strain or another?
In a word that rhymes with mo?
No.
No. Thus far, we don't have that kind of information. That would be awesome, but we don't have it yet.
All right. Is cannabis detected in blood tests?
Yes. And so this is very important. I'll give you an example. In the state of Ohio, if you have a medical marijuana recommenders card, you are allowed to purchase cannabis products and use it for your medical condition. But your employer does not have to honor that. And if they have a policy that they would fire you if you were tested positive, you could still lose your job. And so that's a very big sticking point as we deal with cannabinoids. And yes, it will show up on a blood test.
All right. Thank you very much for that. Now I'm going to change your direction here because I see that we have a half hour left, and I do want to get to two major subjects of what you were going to speak about today. One is the access to care in rural America and using telemedicine. All right. And then the other one we'll get to is about the COVID. Okay. And the flu. Okay.
So let's start by talking about access to care and telemedicine. So for decades, people impacted by MS and other people that experience chronic conditions have been demanding better access to care. They've been demanding telemedicine or something similar, and it was met with silence. It wasn't until a global viral pandemic, COVID-19, that healthy people couldn't go see their doctors. And so suddenly, all of these options for telemedicine materialized. And if there is a silver lining underneath the nastiness of COVID-19, it's the adoption of telemedicine here in the United States. At least that's my opinion as a doctor practicing neurology during this pandemic. So the federal government here in the United States has liberalized the laws which previously prevented doctors from billing for telemedicine, for crossing state lines with telemedicine, for seeing new consultative visits with telemedicine. And at least in Ohio, those laws are locked in place at least until the end of January. Now, what does that mean? That means that we now have a unique opportunity to conduct medical visits via the interwebs, like we're doing right now. So in my office on March 21st, when the governor of Ohio closed the state, we looked at each other and said, let's do some telemedicine. And we figured out a way to jump online with patients, and we're doing what we're doing now. And it has changed everything. I think that telemedicine is the future, because so many people did not have adequate access to subspecialists, and they do now. I have done more out-of-state consults. I've done out-of-country consults. I have taken care of people where I see them weekly on camera, where they would never be able to come in that commonly because they don't have a ride, or because they live in Indiana, or because they work full-time. But we've been able to provide what I think is a very high level of care through telemedicine. Telemedicine is not perfect, and it is my hope that after the global viral pandemic has ended, after COVID-19 has been under control, that we do not revert the laws back to the ancient days of yesteryear. I hope that we maintain the opportunity to provide care for people impacted by MS and with other chronic conditions through telemedicine. And I submit to you that I think 50%, half of all visits done for MS could easily be done on the interwebs. I absolutely believe that. Now, interestingly, way back in March, Stuart and I, on a Saturday, jumped on camera where he was in Florida and I was in sunny Ohio, and I was on my end of the camera and he was on his end of the camera. And I played doctor and he played patient. And together we did a telemedicine visit, except we recorded it and we published it on both of our YouTube channels. And the intention was to demonstrate that you can conduct a legit, real world, real deal Holyfield visit, and you can do real neurological testing, and you can learn something about the human, and you can make excellent clinical decisions. And I am grateful for Stu for allowing us that opportunity. And I am grateful for my patients that get online all day with me to allow me to provide care while keeping them safe and away from the fray. So telemedicine, I think, is a really, really important thing. Now, I want to extend the discussion beyond telemedicine because the topic was access to care. And the interwebs have a good and a bad to them, but I think there's a giant good to be had as it relates to connecting human beings together, creating community, and educating. And as an example, I'll highlight MS Views and News. So the organization that is sponsoring this evening, that brought me here, that allowed us to have this conversation, is one of the most developed and mature deliverers of MS education that I've ever seen. And if you don't know what I'm talking about, I want you to go to YouTube and check out the MS Views and News YouTube channel. Or I want you to go to their homepage, their webpage, because what you will find is a repository of hundreds of cutting-edge lectures by the who's who in MS, talking about what they're best at, delivering the newest, latest, and greatest information. And it's available for free on the interwebs on their YouTube channel. And there are other resources out there. But my point here is it's an awesome way to teach, and it's an awesome way to learn. And I think it's a very, very important tool to use as we live our best lives despite having multiple sclerosis. Thank you for that question. Stu, back to you.
So, sorry about that. And I do want to thank you for bringing that up about MS Views and News. Of course, I'm going to definitely agree with you about everything you said. So that was, by the way, that was a very interesting phone call that Dr. Boster was telling you about that he and I did, and we did it to educate people because this was at the very beginning of the pandemic and people just had no clue what they were going to do. And like Dr. Boster said, he played doctor and I played patient, and it was funny that we were able to do that. And we made it a real call, and I brought up things that he had to do, and he was inspecting my eye through the lens of the laptop, and it was very interesting to see what he was able to do. So I want to say thank you for that. Now, going into some of those questions, and even jumping before that, there's a person that is on here that she has been waiting for a response to a question that we don't have any major topic for it, but they just want to know about clean eating, if there's anything that you could recommend for a diet to follow or not, and then we'll get into the questions about this topic, okay?
With pleasure. So talking about diet, first of all, there's no diet that has been proven to slow multiple sclerosis. Allow me to repeat. There is no diet that has been proven to slow multiple sclerosis. Now, you may think I'm a liar or I'm fibbing, because if you go to Borders bookstore and you walk in and tell them you have MS, they'll say, oh, great, come over here. And they'll show you an entire row of books that are written by people that have initials after their name like mine. But the point is, if you look at the science, there's nothing that's been proven to slow MS. And you may say, well, then who cares about a diet? But I do, because there is good evolving evidence that through diet, you can improve very, very key symptoms: thinking and memory, mood, and energy. All right, those are really, really big symptoms. And it is my opinion that the best diet is a whole food, real food diet, where you avoid foods that have ingredients that you can't pronounce with chemicals, because that's not food, that's a chemical. You avoid fast food because that's not actually real food. If you buy a fast food burger and you leave it out for 3 years, it looks like a burger. It doesn't rot. And that's not okay, because real food rots. Real food should only be stored in your refrigerator. It shouldn't be able to be stored in your cupboard, because real food goes bad. And I also think if you avoid sugar-laden foods and fried foods and heavily processed foods, you're going to find within a month that your entire life has changed. Now, if you're looking for a diet, like a recommended diet, my fave diet within the MS space is Overcoming MS. The Overcoming MS diet, which in my opinion is a little on the strict side, is a really, really lovely diet. And I think that it's very, very nice. And so if you are trying to learn about an MS diet, that's one that I think is pretty solid. But even just adhering to something like Weight Watchers is a great way of learning about what you're eating and learning about nutrition. And so I challenge you to try that out. I think you'd be shocked at what you find.
Thank you for that. Now, going into about the access or things like that, person writes that they just went on to disability and now receiving Medicare. I'm still covered for my Part B under my wife's plan. I'm currently taking XYZ drug. What resources are available to help me choose between a supplement plan or an Advantage plan? Do you have an answer for that?
This is such an important question, and it is so challenging to figure out. And most people are completely left on their own. Now, let me share a couple different resources. I'll share 3. Resource number one is on your channel, Stu, because you have interviewed experts in this field. And so if they go to your YouTube channel or your homepage, they will find lectures on this topic. And if they haven't seen them, they should. Number two is the National MS Society. And so the National MS Society, the local chapter, has access to pro bono lawyers. Not every chapter does, and not every lawyer is available, but they have access to pro bono lawyers where they can help guide you. All right. So those are two really, really important references. The third, if you really want to get into this, is to hire a lawyer who is an expert in this area to guide you. And in some ways, it's probably worth it to spend a couple $100 to have an expert say, don't do this, do that. It's very, very challenging. One more pro tip when you're considering open enrollment is look at whether your current providers are covered under that enrollment. I've had patients, and this breaks my heart, where they get a new insurance, they pick a plan, and then they find out that I'm not covered in their plan, and they have to leave my practice. Not they didn't want to, but it turns out that the plan they chose disallowed them from coming to see me. So the take home here is, however you slice it and dice it, whether it's on your homepage, whether it's the National MS Society, whether it's hiring a hired gun, doing some homework ahead of time in preparation for picking your plan is really, really important.
Thank you. So next, are there any at-home assistance options available on Medicare for the MS community that needs a little help? Light housework, cooking? I guess that might be like an aid, and I don't know if you have an answer for that.
I do. So home health is something that I have used extensively since March. All right. In the setting of a global viral pandemic, many of my patients do not want to go to a physical therapist suite. They don't want to go to an occupational therapist suite. They are looking to stay at home because they're immunosuppressed in some cases, and they're worried about infection, et cetera, right? And so we've used home health for those purposes. But home health traditionally also offers in-home nursing and in-home assistance, medical assistance. And government plans, including Medicare, cover them. And so if you find that you have needs at home, maybe you need help getting out of bed and getting showered and getting dressed. Maybe you need help getting your breakfast set up in the morning. Maybe you need help getting out of your chair in the evening, getting back into bed. Talk to your provider and bring on board a home health company to help you do that. And here's the thing. The home health company is going to be paid by your insurance. They're going to vet your insurance to make sure they can get paid before they come out. And so there's no onus on you as a human being living your best life despite MS. You ask the company and they'll find out if they can get covered long before they come out to see you. And I think that you would be very happily surprised because most of them you can.
Thank you. Interesting question. Once COVID is contained, do you think that MS neurologists will continue to use telemedicine, especially for those that live so far away in rural America, for instance, from their doctors? Do you think it might still be an option for them?
I pray and hope the answer is yes. Yes, 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 yes. Here's what it's going to boil down to. If Medicare remains available and continues to reimburse doctors for telemedicine visits, the whole country will follow suit because third-party payers follow Medicare guidelines. And so Medicare now reimburses me, Aaron, for doing a telemedicine visit, all right? If Medicare changes that, let's say they give me a third of the amount of reimbursement, I won't be able to make ends meet. I won't be able to offer telemedicine in the same capacity because it won't generate enough income for me to pay for my services. So it is my strong hope that the laws do not go all the way backwards. Is it valuable? 100%. Is it something that we should continue? In my opinion, yes. Now, if you're at home listening to me and thinking, well, how can I affect change? You can. You know what you do? Write your congressman. Write your senator. I'm being dead serious. Write a letter and say, dear senator, dear congressman, my name is so-and-so and I have a chronic condition. and I benefit from telemedicine, and I demand that you leave it alone and allow doctors to continue to care. And if enough people do that, we will impact change, and we will have an option to bring care and access to human beings for decades and generations to come.
Okay, thank you for that. So now, do you have time to two subjects or just one?
I have time for anything you want.
Oh my gosh, that's great. Why don't we talk a little bit about research? Do you have anything to talk about on that?
I do. So years and years ago, when I was applying for residency, so I was a medical student and I knew I wanted to be an MS doctor and I knew I needed to go to neurology to do that, I went to Case Western Reserve, which is a fantastic medical school in Cleveland, Ohio. And I'll never forget, I came into this doctor's office and he took his shoes off, which I thought was really weird. And so he put his socked feet up on his desk, relaxed. And he says, young man, because back then I was a young man. He says, young man, what do you want to do when you grow up? And I said, sir, I want to be an MS doctor. He said, are you going to go into academics or private practice? And I was honest and I said, I don't know the difference. And he said, let me teach you. He said, the difference is if you go into private practice, all you can do is peddle what's currently available. And that's not good enough. But if you go into academics, you can develop the next greatest thing. And I thought, okay, I'm going to go into academics. And I did. And I was in academics for a very long time. And that guy was actually wrong. I'm now working in a standalone MS center of my own creation called the Boster Center for MS. It's a private practice and we do research and it's awesome. And the bottom line is he was only half wrong and half right, because the part that he was right about is the fact that we need to study the newest things. We need to bring to the table the latest and greatest. We need to create options for patients to fight back against the disease so that we can find the next best cure. If you think about the fact, I've mentioned a couple times on this call that there are 22 different drugs available for MS. 22 different drugs. Now ask yourself the question, if people impacted by MS never volunteered, 0 people volunteered, how many drugs do we have available? None. We'd have nothing. It's by the efforts of research, by people with impacted by MS that volunteered their bodies, that we've been able to discover the medicines that we have today. And I am very proud that I continue to offer those options. And I want to share with you one area of research that I'm super excited about, and it's called BTK inhibitor. Now, BTK does not stand for bind, torture, and kill. BTK is protein tyrosine kinase inhibition. And a BTK inhibitor is a pill that you take once a day, which does 2 really weird things. Weird thing number 1 is it blocks B cell transmission. So B cells are talking, and it doesn't murder the B cells, it just makes it so you can't hear them. And so the signal is not transmitted because nobody can hear it, which is really, really cool. The second thing, which is more neat to me, is that it works on microglia. Microglia are cells inside the brain that we've never been able to affect. And we know that in MS, they get really, really riled up, and a BTK inhibition calms them back down. So right now, there is a tremendous effort. Multiple different manufacturers are doing clinical trials. We at the Boster Center are participating in these trials. And I really think that BTK inhibition is going to become the next best thing. It's going to become the next new wave of therapeutics to help with MS. I'm very hopeful that BTK is more than just an anti-inflammatory, and it might do some of that neuroprotection that I was talking about some time ago. So that's an area of research that I am super excited about.
Thank you for that. All right, so there's a question concerning research and what has been learned of leaky gut and MS.
So it's fascinating, Stu, that there are connections in the body that we don't fully understand. For example, did you know that there are more bacteria in your body than there are human cells? That's true. Your body has more bacteria inside of it than human cells. That's true. And the vast majority of those bacteria live inside your gut. And what we've learned is that the bacteria in the gut can alter and change your immune system. And so there are some conditions that are gut conditions like Crohn's or ulcerative colitis where this has been very well studied. But in the area of MS, it's a much earlier point in the evolution of understanding. And what we do know is that people impacted by MS can have something called dysbiosis. Dysbiosis means they have a bunch of bad bacteria in their gut, like the wrong kind of bacteria. And it's believed that these abnormal populations of bacteria might negatively impact the immune system. And so what we don't know yet is how to change it. We don't know yet which are the good bacteria and how you transplant the bad for the good. And there's a lot of ongoing research. So there are over-the-counter supplements that you can take called probiotics. And probiotics are a bottle full of good bacteria. And I actually recommend probiotics to a lot of my patients to help them with diarrhea or to help them with constipation. But in the future, I imagine as we become smarter and understanding the brain-gut connection and understanding how to correct dysbiosis, we will actually prescribe certain colonies of bacteria that you take into your mouth to repopulate your gut to help your immune system. It's very, very exciting.
Thank you. Person has asked, and I don't even know what this word is, but what are your thoughts on the TOA patch?
So that's a product that I would prefer not to talk about today, but okay. I have 3 comments as it relates to non-FDA approved therapies or non-allopathic therapies. The first comment is it needs to not be too expensive, right? So each individual human has to decide if something is too expensive. Number 2 is it needs to not be dangerous because certain therapies are dangerous. For example, you can take cyanide naturally and die, right? That's a natural substance that'll kill you. And so there are other substances that you can take that are quite dangerous. The third, after you talk about not being too expensive and not being too dangerous, is that it can't be instead of something that works. So in this example, if you can afford it, it's not dangerous, and you're not doing it instead of something else, I'm willing to talk to you about it and consider it. And if it were to help you, that's great. And if it doesn't help, at least it's not too expensive and it's not going to put you in danger.
Okay, thank you. Next question on the research, and then we're going to get into our final topic of the day. On the research, is there a blood test yet to know more about your MS, if you can get MS, or what your advanced stages might be for MS?
So not yet, but we're darn close. And so there's a test called neurofilament light chain. So when you have a neuron, all right, so a neuron's like a long straw, and that straw portion is called the axon. And if you crack the axon, it spills all of its guts into the bloodstream. And the guts include neurofilament heavy chain, neurofilament medium chain, and neurofilament light chain. Now, it turns out that the blood level of neurofilament light chain, the higher the blood level of neurofilament light chain, the more you see neurological disability. And that's not just from MS, that can be from traumatic brain injury or stroke or ALS or what have you. But in this setting of MS, we have really started to study neurofilament light chain, both in spinal fluid and now in blood, and we're able to tell some fascinating things. For example, we can identify a relapse 9 months before it actually occurs. For example, we can identify whether or not you're responding to a medicine. For example, we can identify if you're having progression of disability. Now, the important point to keep in mind is it's not prime time yet. So you can't just go to your doctor and say, order my neurofilament light chain. We're still working on it, and I think it's going to be a handful of years before it's commercially available. And I am really excited about neurofilament light chain. I think it's going to change near everything.
Great, thank you for that one. Next, with regard to a flu shot, best time of the year to get one, and also for people to know if they should have the live or the dead version, please.
Yep. So the flu, which is influenza, kills people every year. The flu is nothing to joke about. And if we've learned anything from coronavirus, it's that we need to take viruses and we need to take the flu more seriously. Now, if you have multiple sclerosis, it is never recommended to take a live vaccine or a live virus. So if you're offered a live virus or a live attenuated virus, my opinion is don't do that. Fortunately, the flu vaccine, the shot is dead. And so it's a dead virus. So even if you have a suppressed immune response, it's not going to trigger an infection. And we don't have any evidence that it would trigger an attack. And so it's my opinion that barring other reasons that you get a flu shot. Now, do not get off the line tonight and say, Dr. Boster said to get a flu shot, so I'm going to get a flu shot. Of course, you have to ask your provider because every human being is different, and there may be specific reasons why you do or don't need to do that. But generally speaking, I am a big proponent of yes, 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 get your flu shot and make sure it's a dead vaccine. Now, the flu vaccine is very interesting. What they do is they take last year's strains of flu and they grind it up in a blender and kill it, and then they inject it into your arm and they show your immune system last year's strains of flu in hopes that this year's flu has some of the same strains. And so it's not oftentimes fully protective, but it's better than nothing. Now, a lot of people ask me, well, hey, I want a flu shot, but I'm on therapy X or Y. And again, speaking in generalities, the better part of valor is to get the flu shot when it's available. Because we know that, for example, even if you're on like a B cell killer and you take a flu shot, it'll still work. It just won't work 100%. It might work like at 70%, which is a lot better than nothing.
Thank you. Now, I'm not there yet. I'm not getting into COVID yet because I forgot one subject and I just need you to be brief about this, all right? Tell us about complementary medicine. What would you suggest for complementary medicine?
So I'll just run back to the same thing I said earlier. Complementary medicine is a way of saying stuff I didn't study in med school, right? Which doesn't mean it doesn't work. It just means we don't study it. The best example is acupuncture. In the United States, acupuncture is complementary. In China, it's standard of care, right? So as long as it's not too expensive, it's not dangerous, and it's not instead of something that we know works, try it. And if it works, tell me about it, and I'll tell a bunch of other people about it.
Thank you. All right, we're into our last subject, COVID and MS. All right, so the first one that is asked everywhere we go, people want to know what vulnerability people have, and I'm not going to mention any medication names. Is there any vulnerability to using a medication, an active MS medication right now with higher chances of getting COVID?
So just to level set our understanding, first off, having MS does not increase the risk to contract COVID. And so having MS does not increase the risk of more severe COVID unless you're immobile, unless you can't move your arms and legs, right? There's a misconception amongst many people and families impacted by MS, that's exactly right, Stu, that because you have MS, you're at increased risk, and that's actually not true. Number two, the way that you control exposure to the virus is what you just did by distancing yourself socially, by washing your damn hands, by wearing a mask. These are not nonsense. These are actually terribly, terribly important, because the way that you get the flu or the way that you get coronavirus is somebody spits on you, because when you talk, it aerosolizes your saliva and it hits your face and it gets in your eye and your nose and your mouth, and that's how you get it. So if you stay 6 or 8 feet away from people, if you sanitize your hands when you touch stuff, and if you wear a mask, it prevents transmission of saliva, and it can really make a big deal. Recently, there was a statistic that was very bothersome to me, that if everyone in the United States had worn a mask, we would have saved over 130,000 deaths. 130,000 deaths. And that's a really, really big deal. So that's the first comment. The second comment is that there is a belief that if you are taking a medicine which suppresses your immune system, it increases the risk of a more severe COVID infection if you got infected. And that is a good thing to keep in mind, although I'm not sure if it's 100% true. But for the sake of this telephone discussion or this web discussion, I want us to act as if suppressing the immune system increases the risk of a more severe infection. So does that mean that you shouldn't treat MS? No, it doesn't mean that. if you have MS, you're still going to have MS after the global viral pandemic. And I don't want to allow you to become neurologically disabled while the pandemic's going on. So here's my take. Let's treat the thing we know you have, and then let's mitigate the risk by doing smart things. For example, I have patients that have taken massive hardcore immunosuppression, except they live nowhere near anyone else and they don't go around anyone else and they work from home and they are safe. And so are they at increased risk? I'm not exactly sure they are. I think at the end of the day, it's not one size fits all. And we have to take into consideration all of the good, the bad, and the ugly, including the benefits of treating MS, including the potential risk of a more severe infection. And then together with your team, you come up with the best answer for you.
Thank you for that. And don't forget, they should be using hand sanitizer, all right? Trademarked.
That's exactly right. So you either wash your hands or you use hand sanitizer. And for a limited time only, if you message Stu, he would be happy to send you. I'm just joking. I made that part.
I would be more than happy to send one per person if they want to send me something to cover the postage or whatever. We would be happy to do that. But in addition to the face shield, should they be wearing glasses when they're near to being around people in public, or a face shield?
So my opinion is that that's a good idea. Because the problem with COVID infection, or flu infection for that matter, is that the virons that are spewed out in your sneeze or in your cough hits your face, and it hits the mucous membranes of your eyes, or it hits your nose or your mouth. And so, I've seen people, they wear a mask like this.
Right.
So their nose and their eyes are completely exposed. And so if you look at a medical healthcare professional working in a hospital, you'll notice that they're wearing a mask and a face shield. And in my opinion, that is probably safer than just wearing one or the other.
Great, thank you. All right, so another question that comes up by many these days is that they want the ability to be able to do some travel again. And the questions come to us a lot, about air travel, even car travel. They're afraid to stop at rest areas along the way, or to even get out of their cars where there are other people, or maybe they, should they be running in the woods, or should they be packing with them in their car a porta potty, so they could stop on the side of the road behind a building somewhere. What are your answers? I mean, what do you think about all this?
So if you lived in your basement by yourself and you had hermetically sealed food that you nuked in the microwave, and you did that for the next 6 months, you probably would never get COVID. Anything shy of that is a slight risk. And the real world, the world that you live in, the world that I live in, the world that people who are listening to us right now live in, comes with risk. And so we have to mitigate risk. I'm not recommending that you live inside your basement eating hermetically sealed food, but I am recommending that you're smart. And so if you are traveling, let me ask you, how important is it that you travel? Is there any other way to do it? I'll give you a great example. When we planned this event, you planned to fly from Florida to Dayton, Ohio, and I planned to drive from Columbus to Dayton, Ohio. And because of risk of COVID, not just to you and I, but to the people we'd be talking to, we did something a bit different. You're in a studio, I am in my living room, or my dining room, I guess, and we are delivering this lecture. And I hope that people appreciate your efforts in putting this together, because let's be honest, it's a lot are involved. And yet it was a way that we accomplished our goal of educating people impacted by MS and bringing education to even rural communities, and yet we mitigated the risk. And that's just an example. And so I think that we have to use logic, and I think that we have to apply the best practices that we can. I'll give you one other example. I take care of a person who has MS, and they're a police officer. They can't work from home. That's not how cops work. And so they have altered the kind of duties that they do. because they are suppressed in their immune system, and they take precautions when they do it. And they haven't stopped working as a cop. They've just changed what they do.
Thank you. Now, even for me to get here to the studio, I live in South Florida. I drive up here to Central Florida. We have our producer's studio, which is where we hold most of our virtual events, which is great because we can change this wall behind me, you know, to show the different sponsors for the different programs. And it allows me to feel like, you know, I'm doing a program live, all right? It's a great thing, but I still have to get here. I still have to make my stops along the way. And, you know, I have my K95 masks that I will wear when I have to, you know, go into a rest area, or I will wear a thicker fabric mask so that way it does protect me better. And I still keep my 6 feet away from people, and I do what I have to do to stay as safe as I am. I'm over 60. I hate to say that, but I am. And I do not consider myself being at higher risk. All right. I do what I do to stay as safe as I can. I will travel by air when I can travel, you know, to get to different places. And, you know, we do what we do. We travel with certain airlines that we know are safer than others as far as doing this. I'm not going to name names right now, but anybody can connect with me afterwards, and I will speak with them about that. There are different factors that you can do when you are places. You do not have to sit next to people. You can be more segregated, so to speak, and to feel as, you know, as comfortable or as safe as you can be. Life does go on, and we have to make it as you know, do what we can do to be safe and be smart safe about it. So there are questions coming in. I do want to say that. People are just wanting to know, is this webinar going to be available afterwards? There are people that they want to share it with their family and friends. The answer is yes, but it's not right away. We are about a month behind right now on publishing our videos, okay? We are doing, for everybody that is out here, and Dr. Boster, I'm not taking anything away from you right now. I will get back to you in a minute, but we are providing 6 to 8 virtual programs a month right now, and that is because we can. All right, and we are able to do this, and we have a great grant writer that is able to put all this together. And Jennifer, she's going to watch this later on. That is Jennifer. She's, you know, writing up these grants and these sponsorships, and that is fabulous. We have many different program series that we will be coming out with in 2021 that bring in the patients and is all relative to what, you know, what is going on each month and going forward for the patients. So we will be able to answer as many questions as we can that, you know, people are asking, and we do have Dr. Boster, thankfully, is available often. We have other doctors and nurse practitioners that we use that, you know, a lot of people ask, why don't we expand out of our wheelhouse? And we say, why? I mean, these people are bringing you the best of the information that they can, and we're very happy to work with them. So we will continue working with them. And Dr. Boster, I want to give you free time right now to talk about what you want to speak about for 5 minutes, okay? And then we are going to end this program because it is a little bit beyond where you wanted to be. But I just want to give you 5 minutes to speak about whatever you want to talk about.
That's super nice of you. You know, I'll use part of those 5 minutes again to thank MS Views and News for the opportunity to educate. It's a privilege and an honor when I get to try to help someone live their best life with MS. So thank you, guys. I want to thank our sponsors tonight, Novartis and Genentech, for creating this opportunity and making this possible. And most importantly, I want to thank the people that gave up part of their evening to up their game and learn how to live their best life despite having this condition. So thank all of you. My name's Aaron Boster, and I want to thank everyone out there for allowing me to educate you and learn about MS with me. As I mentioned earlier, I'm the founder of the Boster Center for MS here in Columbus, Ohio. We're seeing patients literally from around the globe, both in the office and on telemedicine. We accept all major insurance carriers, and we're actively enrolling for clinical trials right now, just like the BTKI trial that I mentioned. If you don't have an ability to get up here, I do want you to check out our YouTube channel. You can type in my name, Aaron Boster, MD, into YouTube, and I put out a weekly video on MS. I also have a presence on Twitter and Facebook, and you can certainly find me there. So with that, I just want to thank everyone for their time tonight. It's rare that we step outside of our normal routine, particularly late at night, and I'm so grateful that we had this opportunity. So Stuart, thank you very much, and back to you.
Thank you very much. And for those who haven't figured it out, I am Stuart Schlossman, and yes, I have multiple sclerosis, and that's how this all came about to begin with 11 years ago when we held our first program, and we have now held, between our true in-person programs and virtual programs, we are nearing 700 events since we began as an organization, which is just about 11 years ago. And so I do have wonderful staff and volunteers, and of course our video producer, Bill Shanley from Orlando Production, who I have to thank for everything that he does for us as well. And again, though, we have to thank those that come on to our programs, because without you, we cannot do our programs. So please share with others that you do know with multiple sclerosis and tell them why they should be on our programs. Okay?
Dude, one request that I'll make while we're on the interwebs, I want to participate in the 1,000th program.
Oh, you got it. You got it.
Right,
now I got to go back and count them all, though. Now I have to go back and count them all. All right, so.
Thank you so very, very much.
Fantastic. And again, thank you everybody for being online, and I do want to thank Novartis and Genentech, and let's just call it a wrap, okay? Thank you very much.
Good night, everyone. Take care.
Bye-bye.